Welcome to Bookfulness. This is our 15th deep dive in the series focusing on clinically oriented anatomy, 8th edition.
Hello. Last time we were talking about the mediastinum, that central chest compartment, and the pericardium, the sort of protective sac around the heart.
That's right. And today we're going inside that sac. We're really getting into the heart itself.
The engine room.
Exactly. We want to understand its internal layout, how it's wired, the conduction system, and also the major pipes connected to it, the great vessels, especially up in the superior mediastinum.
It's like getting the blueprint for this incredible biological pump. We need to see how all the parts fit together. Things like, little details on the atrial septum or why one ventricle wall is so much thicker than the other. It all has a reason.
So let's start with the basics. The heart's a pump. Obvious, right? But the complexity is in the coordination, that rhythm. What's the core function beyond just, pushing blood around?
Well, fundamentally, it's about generating electrical signals, impulses, and then transmitting them incredibly quickly and precisely. The timing has to be perfect.
Like a conductor leading an orchestra.
Kind of, yeah. The atria, the top chambers, they have to contract first to properly fill the ventricles below them, sort of priming the pump.
Okay.
And then the ventricles need to contract powerfully and together to push that blood out either to the lungs or the rest of the body.
And that coordinated action is the cardiac cycle, right? The diastole and systole phases.
Exactly. Two main phases. You have diastole, that's when the ventricles relax and fill up with blood. Some of it flows in passively, and then the atrial contraction gives it a final push.
So that's the reloading phase.
Right. And then systole. That's the big squeeze. The ventricles contract forcefully, ejecting the blood. This whole fill-eject cycle, diastole systole, it's just PEDS, driven by that specialized electrical system we'll unpack later.
Before we dive inside, let's just orient ourselves externally. Where exactly is this pump sitting? Because I think a lot of people picture it dead center, but it's actually tilted, isn't it?
It is, quite significantly. Anatomically, we talk about its base and its apex to describe its orientation. And counterintuitively, the base isn't the bottom.
Right.
It's the broad, upper, and sort of posterior aspect. It's where all the big vessels connect the vena cavae, the pulmonary veins, the aorta. It's the attachment point, really.
Okay, so the base is the top back. What about the apex?
The apex is that blunt, sort of conical tip that points downwards, forwards, and crucially to the left. And interestingly, it's formed entirely by the muscle of the left ventricle.
Ah, so the shape itself tells you which chamber is doing the heavy lifting for the whole body circulation.
Precisely. The sheer muscle mass of the left ventricle dictates that apical shape.
And the heart isn't just floating there. It rests against things. What are its surfaces?
We usually define 4 surfaces based on what they face. There's the sternocostal surface, that's the front one, right behind the sternum and ribs.
Makes sense.
Then the diaphragmatic surface, the bottom aspect, which literally rests on the diaphragm muscle.
Okay.
And then you have the pulmonary surfaces, a left and a right one, where the sides of the heart nestle against the lungs.
And knowing these surfaces and their borders is really important for interpreting things like chest x-rays, I imagine.
Oh, absolutely.
Yeah.
The edges, the borders, the right border mainly formed by the right atrium. The left border, mostly the left ventricle, they create that distinct heart shadow, the cardiovascular silhouette.
Yeah.
If one chamber enlarges, say the left ventricle in hypertension, that silhouette changes. The borders shift. It's a key diagnostic sign on imaging.
Okay, let's go inside then. Starting with the right atrium, the chamber that receives all the deoxygenated blood coming back from the body. Where does it all flow in?
The right atrium is like the main receiving dock for the venous system. Blood comes down from the upper body via the superior vena cava, the SVC. It comes up from the lower body via the much larger inferior vena cava, the IVC. And very importantly, it also receives blood from the coronary sinus.
Which drains the heart muscle itself.
Exactly. Almost all the venous blood that supplied the heart walls collects in the coronary sinus, and it empties right into the back wall of the right atrium.
Now, the inside of the right atrium is fascinating because it looks like 2 different types of tissue fused together. How is that inner wall structured?
It really does show its developmental origins. There's a clear division. The posterior part, where those big veins empty, is called the sinus venerum. It comes from an embryonic structure called the venous sinus, and because of that, it's very smooth-walled and relatively thin. You want smooth walls there to handle that large inflow without too much turbulence.
Makes sense for managing flow. And the other part, the front part.
That's the rough-walled part. This includes the little ear-like pouch called the right auricle. This section is lined with prominent parallel muscular ridges. They look a bit like the teeth of a comb, so they're called pectinate muscles.
Pectinate, like pectin comb. Okay.
Right. And this rough area actually comes from the true original embryonic atrium.
So you have the smooth inflow area and a rougher, more muscular area. What marks the boundary between them?
Externally, there's a faint groove called the terminal sulcus. But internally, the division is marked by a very distinct muscular C-shaped ridge running vertically. This is the crista terminalis.
Crista terminalis. And is it just a landmark?
It's more than just a landmark. It's functionally important because the heart's main pacemaker, the SA node, sits right at its upper end. And the crista helps direct the electrical signal spreading from the SA node across the atrium towards the next node, the AV node, kind of guiding it away from the openings of the vena cava.
Very clever. Now let's talk about that feature on the wall separating the two atria, the interatrial septum, the oval fossa.
Ah, yes, the oval fossa. It's this shallow depression, usually about the size of a thumbprint, found on the interatrial septum. It marks the location of what used to be an opening in the fetal heart, the oval foramen, or foramen ovale.
And this was a crucial bypass in the fetus, wasn't it? Avoiding the lungs.
Absolutely essential. Before birth, the lungs aren't functioning for gas exchange, and they represent a high-resistance circuit, so you don't want to pump much blood through them. Oxygenated blood returning from the mother, via the placenta, comes up the IVC into the right atrium.
Okay.
Because the pressure on the right side of the fetal heart is higher than the left, this oxygenated blood gets shunted directly across, through the oval foramen, into the left atrium. It bypasses the pulmonary circulation, a right-to-left shunt.
And then at birth, when the baby takes its first breath, everything changes. What actually closes that hole?
It's a purely mechanical pressure change. That first breath inflates the lungs, dramatically decreasing the resistance in the pulmonary vessels. Suddenly, blood flows easily to the lungs. This causes the pressure in the right atrium to drop significantly.
Okay, lower pressure on the right.
Simultaneously, the large volume of blood now returning from the newly functioning lungs floods the left atrium, causing the pressure there to increase sharply. So now you have higher pressure on the left side than the right.
Ah, the pressure reverses.
Exactly. And that higher left atrial pressure pushes the flap valve of the oval foramen, septum primum, against the opening septum secundum, effectively sealing it shut. Over time, this fuses and becomes the permanent oval fossa.
But sometimes that fusion isn't perfect. The book mentions that a small opening, a patent foramen ovale or PFO, is actually quite common.
It is surprisingly common. About 15 to 25% of adults have a small probe-patent foramen oval. Usually it's clinically insignificant because the left atrial pressure normally stays higher than the right, so it functions like a closed door, preventing any major shunting.
But what if there's a large hole there from birth? A proper atrial septal defect, or ASD.
A significant ASD is a different story. No, because left atrial pressure is normally higher after birth, you get a constant flow of oxygenated blood leaking from the left atrium back into the right atrium. This is a left-to-right shunt.
So blood that's already been to the lungs goes back to the lungs again.
Precisely. It causes a huge volume overload on the right side of the heart. The right atrium and right ventricle have to pump much more blood than they should. Over time, this leads to enlargement of the right heart chambers, dilation of the pulmonary artery, and eventually damage to the pulmonary blood vessels themselves, pulmonary hypertension.
Which can become irreversible, so understanding those pressure dynamics is key. Okay, let's follow the blood flow into the right ventricle. This is the chamber that pumps blood to the lungs. Its internal structure must be adapted for that, right?
Yes, the right ventricle wall is characterized by these very prominent, irregular muscular ridges and beams. These are the trabeculae carneae.
Trabeculae carneae, what's their purpose? Just decoration?
Not at all. They actually increase the surface area and probably help prevent suction effects during contraction. They also play a role in conducting the electrical impulse through the ventricular muscle. They give the inside a very coarse, sort of spongy appearance, except for the outflow tract.
Okay, and the blood flows in through the tricuspid valve. Tell us about that apparatus.
Right. The tricuspid valve sits between the right atrium and right ventricle. As the name suggests, it has three leaflets, or cusps, an anterior, a posterior, and a septal cusp next to the septum.
And they're not just flapping freely, they're tethered, right?
Exactly. Each cusp is anchored by fine, strong, fibrous cords called chordae tendineae. Think of them like parachute strings.
Okay.
And these chordae tendineae, in turn, attach to mounds of specialized heart muscle projecting from the ventricle wall. These are the papillary muscles. There are typically three sets, anterior, posterior, and septal, corresponding roughly to the cusps.
And we often just think of them as anchors, but their contraction timing is critical, isn't it?
Absolutely critical. The papillary muscles don't open the valve, The pressure of blood flowing from the atrium does that during diastole. Their job is to contract just before the main ventricular muscle contracts during systole.
Why the pre-contraction?
By contracting early, they pull on the chordae tendineae and brace the valve cusps, preventing them from being blown backward, prolapsing into the right atrium when the ventricular pressure skyrockets during ejection. They ensure the valve closes securely and doesn't leak.
So they're essential tensioning devices. Now contrast that rough, complex inflow region with the area where the blood leaves the right ventricle.
Right, the outflow tract leading up to the pulmonary valve and the pulmonary trunk is distinctly different. It's smooth-walled and funnel-shaped. This region is called the conus arteriosus, or sometimes the infundibulum.
Why smooth there?
It's all about efficient ejection. Smooth walls reduce friction and allow the blood to accelerate rapidly and smoothly in a more laminar flow pattern as it's pumped toward the lungs. It's a specialized exit ramp.
And within the right ventricle, there's that structure called the moderator band. Sounds structural, but its real importance is electrical, right?
Absolutely. The septa marginal trabecula, which is the more formal name for the moderator band, is this quite prominent muscular band that stretches from the interventricular septum across the cavity of the right ventricle to the base of the anterior papillary muscle.
And why is that bridge so important?
Because it contains a large part of the right branch of the heart's electrical conduction system, the right bundle branch of the AV bundle. It acts as an electrical shortcut.
A shortcut? How so?
It allows the electrical impulse traveling down the septum to reach the anterior papillary muscle very quickly, bypassing the slightly slower conduction through the rest of the ventricular wall muscle. This ensures that the anterior papillary muscle contracts just fractions of a second before the main ventricle wall contracts.
Guaranteeing that preemptive tensioning of the tricuspid valve we talked about.
Precisely. That coordination is vital for preventing valve regurgitation. So the moderator band is really a crucial part of the electrical timing mechanism for the right ventricle.
Okay, let's cross over to the left side now. Starting with the left atrium, which receives the oxygenated blood coming back from the lungs.
Right. The left atrium forms most of the base of the heart, the posterior aspect. Its main job is to receive blood from the 4 pulmonary veins, usually 2 superior ones and 2 inferior ones, bringing that bright red oxygenated blood back from both lungs.
And internally, is it as complex as the right atrium?
Generally, no. The wall of the left atrium is mostly smooth, particularly where the pulmonary veins enter. It functions primarily as a receiving chamber and a conduit to the left ventricle. The only place you really find those comb-like pectinate muscles is confined to the left auricle, that little ear-like appendage.
And on the wall, it shares with the right atrium the interatrial septum.
You can see the other side of the oval fossa story. There's usually a slight impression there, marking the valve of the oval fossa from the left side.
Okay, now blood flows from the left atrium into the powerhouse, the left ventricle. And here, the structure speaks volumes about its function.
It absolutely does. The left ventricle has the hardest job. It has to pump that oxygenated blood out against the high resistance of the entire systemic circulation all the way to your toes in your brain.
So it needs more muscle.
A lot more muscle. The wall of the left ventricle is significantly thicker than the right, typically about 3 times thicker. You can feel the difference easily. This reflects the much higher pressure it needs to generate, maybe 6 or 7 times higher than the right ventricle. Its cavity is also more conical or bullet-shaped, which is efficient for generating that high pressure.
And the inflow valve on this side is the mitral valve.
Correct. The mitral valve, also known sometimes as the bicuspid valve, because it only has 2 cusps, an anterior and a posterior cusp.
Bicuspid, like a bishop's mitre, hence the name.
Exactly. Functionally, though, it's analogous to the tricuspid. The 2 cusps are anchored by chordae tendineae, which attach to 2 very large, powerful papillary muscles, an anterior and a posterior one. Their job, again, is to contract early during systole to prevent the mitral valve cusps from prolapsing back into the left atrium under that immense pressure.
What happens if that mechanism fails? The book mentions mitral valve insufficiency or prolapse.
Right. Mitral valve prolapse is actually quite common, especially in younger women. It happens when the valve leaflets themselves are a bit abnormal, maybe too large or floppy, or the connective tissue isn't quite right. During systole, instead of sealing tightly, one or both leaflets bulge backward into the left atrium.
Creating a leak.
Exactly. Blood regurgitates, flows backward into the left atrium. This backflow is often heard with a stethoscope as a characteristic sound, a mid-systolic click and a late systolic murmur. While often mild and asymptomatic, severe prolapse with significant regurgitation can strain the left atrium and eventually lead to symptoms like shortness of breath or arrhythmias.
Okay. And just like the right ventricle, the left ventricle has a smooth outflow tract too.
It does. Leading up towards the aorta, the wall becomes smooth. The area is called the aortic vestibule. Again, smooth walls for efficient high-velocity ejection into the body's main artery, the aorta.
Now, we talked about holes between the atria, ASDs. What about holes between the ventricles? You mentioned they're actually the most common type of congenital heart defect.
Yes, ventricular septal defects, VSDs, are the most common congenital cardiac anomaly, accounting for something like 25% of all cases. They most frequently occur in a specific part of the wall separating the two ventricles, the interventricular septum, or IVS.
Which part?
Usually the upper, thinner part called the membranous septum. The bulk of the septum is thick muscle, but this small membranous portion near the valves is developmentally more complex and thus more prone to defects.
Why is the membranous part weaker, embryologically speaking?
It forms later in development from the fusion of several different structures. If that fusion process is incomplete, a hole remains. And because the pressure in the left ventricle is so much higher than in the right,
You get a massive shunt.
a massive left-to-right shunt. Oxygenated blood from the powerful left ventricle pours directly into the right ventricle.
Again, overloading the pulmonary circulation, just like a large ASD, but maybe even more severely because the pressure difference is greater.
Exactly. The volume of blood being recirculated to the lungs can be enormous, leading to rapid development of pulmonary hypertension and potentially heart failure if it's a large VSD. Smaller muscular VSDs might sometimes close spontaneously as the child grows, but significant membranous VSDs almost always require surgical closure.
Okay, now exiting both ventricles, we have the semilunar valves, the aortic valve out of the left ventricle, and the pulmonary valve out of the right. They look quite similar, don't they?
They do share a common design. Both are typically composed of three half-moon-shaped cusps, hence semilunar. The aortic valve has right, left, and posterior cusps, while the pulmonary valve has right, left, and anterior cusps. They're built to withstand the high pressures during ventricular ejection and then snap shut tightly to prevent backflow during diastole.
How do those three little flaps make such a perfect seal?
Each cusp has a slightly thickened fibrous nodule right in the middle of its free edge, the nodule. And on either side of the nodule, the edge is thinner and crescent-shaped. These are the lunules.
Okay.
When the ventricle relaxes and pressure drops, the backflow of blood from the aorta or pulmonary trunk pushes the cusps closed. The lunules meet edge to edge, and the three nodules meet securely in the center, creating a really effective seal.
Now, right above the aortic valve cusps, there's a special feature related to feeding the heart muscle itself, the aortic sinuses. This seems almost counterintuitive in its function.
It's a beautiful piece of physiological engineering, just superior to each aortic valve cusp. The wall of the ascending aorta bulges outward slightly, forming three little pockets. These are the aortic sinuses, or sinuses Valsalva. The key is understanding when the heart muscle gets its blood supply.
You mean it doesn't get fed while it's contracting?
Exactly. During systole, the heart muscle, myocardium, is squeezed so tightly that blood flow through the tiny coronary vessels within the muscle wall virtually stops. The heart muscle can only be effectively perfused during diastole when it's relaxed.
Okay, so how do the sinuses help with that diastolic filling?
When the left ventricle finishes contracting and starts to relax, diastole begins, the pressure in the ventricle drops rapidly. The high pressure in the aorta, maintained by its elastic recoil, causes blood to momentarily flow backward towards the ventricle.
Slamming the aortic valve shut.
Precisely. That backflow snaps the aortic valve cusps closed. But as the cusps billow backward to close, they trap blood in those little aortic sinuses.
And the coronary arteries start right there.
Right there. The openings ostia of the right coronary artery and the left coronary artery are located within the right and left aortic sinuses, respectively. So the very act of the aortic valve closing during diastole is what forces blood into the sinuses and thus directly into the coronary arteries, ensuring the heart muscle gets its vital oxygen supply when it's resting and receptive.
That means the heart's own blood supply is totally dependent on having enough time in diastole.
Absolutely. If your heart rate gets extremely fast, like in severe tachycardia, the diastolic filling time becomes very short. That means less time for the coronary arteries to fill adequately. This can lead to myocardial ischemia, lack of oxygen, even if the coronary arteries themselves aren't blocked, simply because there isn't enough time for perfusion.
Fascinating mechanism. Okay, let's trace those arterial supply lines now. We know they start from the aortic sinuses. Let's follow the right coronary artery, RCA, first.
Okay, the RCA arises from the right aortic sinus. It then runs towards the right, nestled in the groove between the right atrium and right ventricle, that's the coronary sulcus. Very near its origin, it typically gives off a really important branch.
The one to the pacemaker?
Yes, the sinoatrial SA nodal branch, which supplies the SA node in about 60–65% of people. So right away, the RCA is critical for initiating the heartbeat in most individuals.
Where does it go after that?
It continues down along the right margin or edge of the heart, giving off the right marginal branch, which supplies most of the anterior wall of the right ventricle. Then the RCA curves around to the posterior side of the heart, still in that coronary sulcus.
Heading towards the crux.
Towards the crux, exactly. The crux is that point on the back where the interatrial and interventricular grooves meet. Near the crux, the RCA gives off another vital branch, the atrioventricular AV nodal branch, supplying the AV node in the vast majority of people, around 85%.
So the RCA supplies both the primary pacemaker and the main electrical gatekeeper in most people.
That's right. And typically, though there's variation, the RCA continues past the crux to become the posterior interventricular artery, also called the posterior descending artery, or PDA. This artery runs down the posterior interventricular groove, supplying the posterior wall of both ventricles and the posterior one-third of the interventricular septum. When the RCA gives rise to the PDA, we call that right dominant circulation, which is the most common pattern.
Given its supply to both nodes, an RCA blockage sounds particularly dangerous for heart rhythm. Now, what about the left coronary artery, LCA? This one often gets called the widowmaker.
And for good reason, sadly. The LCA arises from the left aortic sinus. It has a very short main stem passing between the left auricle and the pulmonary trunk, and then it quickly divides into its two main branches.
Okay, what are they?
The first, and arguably the most clinically significant artery in the body, is the anterior interventricular branch, often called the LAD for left anterior descending. It runs down the groove on the front of the heart between the two ventricles.
And what does the LAD supply?
It supplies a huge territory. The anterior two-thirds of the interventricular septum, via its septal branches, most of the anterior wall of the left ventricle, the apex of the heart, and even part of the anterior wall of the right ventricle. It's a massive supplier.
Okay, that's one branch. What's the other?
The other main branch is the circumflex branch. This artery curves around to the left in the coronary sulcus, running between the left atrium and left ventricle. It supplies the left atrium and the posterior and lateral walls of left ventricle. In left dominant or codominant patterns, the circumflex might even give rise to the PDA instead of the RCA.
This distribution directly explains the patterns we see in heart attacks or myocardial infarction, MI. Where do blockages most commonly occur?
The statistics are pretty consistent and sobering. Coronary atherosclerosis, the buildup of plaque, leading to occlusion, happens most often in 3 key locations, accounting for about 85% of all MIs. Number one, by far, is the LAD branch of the LCA. Blockage here accounts for something like 40–50% of MIs. Massive anterior wall damage often results.
We're widowmaker territory.
Indeed. Number two is the RCA, responsible for about 30–40% of MIs. This often affects the inferior wall and potentially the conduction system.
Right.
And number three is the circumflex branch of the LCA, causing about 15–20% of MIs, typically affecting the lateral or posterior wall of the left ventricle.
So it's the main trunks and their immediate major branches that are most vulnerable. What determines how bad a heart attack is? Obviously the location, but anything else?
Two big factors are the size of the vessel blocked and the speed at which the blockage happens. If a large proximal artery like the main stem LCA or proximal LAD gets blocked suddenly, a huge area of heart muscle dies, and it's often fatal. But the speed is also critical because the heart has a potential backup system, collateral circulation.
Collaterals, like little bypass roads.
Essentially, yes. Over time, especially if coronary atherosclerosis develops slowly over many years, tiny pre-existing connections between branches of the coronary arteries can enlarge. These collateral channels can provide an alternative, albeit usually limited blood supply, to areas downstream of a narrowing or blockage.
So if the blockage happens slowly, the collaterals might have time to develop and keep the tissue alive, maybe.
Exactly. The person might experience angina, chest pain on exertion, rather than a massive heart attack. But if a major artery gets blocked suddenly, perhaps by a blood clot forming on a ruptured plaque, there's no time for collaterals to help. That leads to rapid and extensive myocardial necrosis tissue death. That's the scenario needing emergency treatment like angioplasty, stenting, or bypass surgery.
Okay, so we've delivered the oxygenated blood via the coronary arteries. Now we need to collect the deoxygenated blood and waste products. Where does most of the heart's venous blood go?
The vast majority of it collects into the coronary sinus. This is a large, wide venous channel that lies in the coronary sulcus on the posterior aspect of the heart, between the atria and ventricles. Think of it as the main collecting vein for the heart muscle.
And where does it empty?
It empties directly into the right atrium, specifically into that smooth-walled posterior part, the sinus venerum, near the opening of the IVC.
Does it have major tributaries? Like the arteries have major branches?
It does. The main veins draining into it generally run alongside the major arteries. The great cardiac vein runs with the LAD artery in the anterior interventricular groove. The middle cardiac vein runs with the posterior interventricular artery. And the small cardiac vein often runs with the right marginal artery. They all converge on the coronary sinus.
Okay, that handles the plumbing. Now let's switch to the electrical system, the stimulating and conducting system. This is what makes the heart beat rhythmically on its own.
Right. This specialized tissue is unique. It's modified heart muscle cells that are optimized not for contraction, but for generating and rapidly conducting electrical impulses. Its whole purpose is to initiate the heartbeat and coordinate the contraction sequence atria first, then ventricles.
Let's trace the path of that signal. Where does it all begin?
The starting point, the natural pacemaker, is the SA node, the sinoatrial node. It's located high up in the wall of the right atrium, near the entry of the SVC, right at the superior end of that ridge we mentioned, the crista terminalis.
And it just spontaneously fires.
Yes, it has the fastest inherent rate of spontaneous depolarization, typically setting a resting rhythm of 60 to 100 beats per minute. From the SA node, the impulse spreads out through the muscle walls of both atria, like ripples on a pond, causing them to contract.
Does the signal go straight from the atria to the ventricles?
No, and that's crucial. The impulse spreading through the atria converges on another small node, the AV node, or atrioventricular node. This is located lower down in the interatrial septum near the opening of the coronary sinus.
What's the AV node's job? Just relaying the signal?
It relays it, but its most critical function is to delay the signal slightly, for about 1/10 of a second.
Why the delay?
This pause is essential. It gives the atria enough time to finish contracting and squeeze all their blood down into the ventricles before the ventricles are told to contract. Without that delay, the ventricles would start squeezing too early on partially filled chambers, which would be very inefficient.
Okay, so SA node initiates, spreads through atria, pauses at AV node. Where next?
From the AV node, the signal needs to get down to the ventricles quickly. It travels down the AV bundle, also known as the bundle of His. And this bundle is critically important because it's the only normal muscular connection between the atria and the ventricles.
Why only one connection?
Because the atria and ventricles are otherwise separated by the heart's fibrous skeleton, a dense connective tissue structure that supports the valves. This fibrous skeleton acts as an electrical insulator, preventing stray signals from passing randomly between the chambers. The AV bundle is the specific bridge that penetrates this barrier.
So it funnels the signal? And does it stay as one bundle?
No, very quickly. As it passes down into the top of the interventricular septum, usually in the membranous part, the AV bundle divides into a right bundle branch and a left bundle branch.
And the right bundle branch is the one partly carried by that moderator band we discussed earlier.
Exactly. The right bundle branch heads towards the right ventricle, using the moderator band as a shortcut to the anterior papillary muscle. The left bundle branch, which is usually larger, pierces through the septum and descends on the left side. These bundles then branch out extensively into tiny fibers called Purkinje fibers that spread throughout the ventricular walls, delivering the contraction signal almost simultaneously to all the ventricular muscle cells.
So it's a very organized, high-speed delivery system after the AV node delay. Now, the heart beats on its own, but the nervous system can influence it, right? Speed it up, slow it down.
Absolutely. The autonomic nervous system, ANS, provides crucial modulation. Sympathetic stimulation, think fight or flight, releases norepinephrine, which increases the firing rate of the SA node, increases the conduction speed through the AV node and bundles, and increases the force of contraction. It ramps everything up.
And the opposite.
Parasympathetic stimulation, mainly via the vagus nerve, releases acetylcholine. This slows down the SA node firing rate, slows conduction through the AV node, and generally decreases heart rate, allowing the body to rest and digest.
Now, given that the coronary arteries supply these crucial nodes and bundles, particularly the RCA for the SA and AV nodes, and the LAD for the AV bundle via septal branches, What happens if that blood supply gets cut off by a blockage?
That's where you run into potentially life-threatening conduction problems, what we call heart block. If, say, the RCA gets occluded, you might knock out both the SA node and the AV node.
Remember trouble.
Big trouble. If the LAD is blocked high up, its septal branches supplying the AV bundle might be compromised. If the damage is severe enough to completely interrupt the signal pathway between the atria and ventricles,
That's complete heart block.
that's complete heart block, or a third-degree AV block. The atria keep beating at their own pace, driven by the SA node, if it's still working, say 70 beats per minute. But the signal never reaches the ventricles. So the ventricles have to rely on their own, much slower inherent escape rhythm, maybe generated somewhere in the bundle branches or Purkinje fibers.
And that rhythm is too slow.
Way too slow. Typically only 25-40 beats per minute. That's usually not enough to adequately perfuse the brain and other organs, leading to fainting, dizziness, and potentially death.
Which is why these patients often need an artificial pacemaker. How does that work anatomically? Where do they put the leads?
The most common approach is transvenous pacing. A thin, insulated wire, the lead, which has an electrode at its tip, is inserted into a vein, often the subclavian vein under the collarbone, or sometimes the internal jugular in the neck.
Okay, into the venous system.
Then, guided by fluoroscopy, live X-ray imaging, the lead is carefully threaded through the veins, down the brachiocephalic vein, into the SVC, then into the right atrium.
Navigating through the heart itself.
Yes, you have to carefully maneuver it across the tricuspid valve without damaging it, and into the right ventricle. The goal is usually to lodge the tip of the electrode securely into the trabeculae carneae muscle, often near the apex of the right ventricle. Sometimes leads are placed in the right atrium too for dual-chamber pacing.
And then that lead connects to the pulse generator.
Right. The other end of the lead is connected to the pacemaker device itself, a small battery-powered pulse generator, which is typically implanted in a little pocket created under the skin, usually below the collarbone. This generator senses the heart's own rhythm, or lack thereof, and delivers tiny electrical impulses via the lead to stimulate the heart muscle to contract at an appropriate rate, effectively bypassing the blocked natural conduction system.
Amazing technology, following the natural pathways. Okay, let's zoom out a bit now from the heart itself and look at its immediate neighborhood, particularly upwards the superior mediastinum. Where exactly is this region?
The superior mediastinum is that upper section of the central chest compartment. It's bounded superiorly by the thoracic inlet, the top opening of the rib cage, and inferiorly by an imaginary line called the transverse thoracic plane.
How do we define that plane?
Clinically, it's a horizontal plane passing from the sternal angle, that palpable bump where the manubrium meets the body of the sternum anteriorly, straight back to the intervertebral disc between the T4 and T5 vertebrae posteriorly.
Right.
Everything above that line is the superior mediastinum.
And it's packed full of structures passing between the neck and the rest of the thorax. What's the general arrangement in there, say, from front to back?
It's quite logically layered, generally speaking.
Yeah.
Right behind the sternum, most anteriorly, you find the thymus gland.
Which is mainly active in kids, right?
Exactly. It's large and crucial for immune development in children and adolescents. But it starts to involute and is mostly replaced by fatty tissue in adults, although remnants usually persist.
Okay, behind the thymus.
Next comes the venous layer. The large veins tend to be more anterior than the arteries here. You have the left and right brachiocephalic veins, formed by the union of the internal jugular and subclavian veins on each side. These then merge to form the large superior vena cava, SVC, which descends to enter the right atrium.
And the SVC is a major access point for central lines.
It is. It collects all the venous blood from the head, neck, upper limbs, and upper chest. Central venous catheters are often guided down into the distal SVC for monitoring pressure or delivering medications.
Okay, so thymus, then veins. What's behind the veins?
The arterial layer,
Yeah.
dominated by the magnificent arch of the aorta. As the aorta ascends from the heart, it arches backward to the left over the root of the left lung.
And it gives off its major branches here.
Right here. From right to left, coming off the top of the arch, are typically three great arteries. First, the brachiocephalic trunk, a short, thick vessel that quickly divides into the right common carotid, for the right head neck, and the right subclavian artery, for the right arm. Second is the left common carotid artery, and third is the left subclavian artery. These supply the left side of the head, neck, and the left arm, respectively.
You mentioned the arch. Are there any important variations or anomalies there?
There can be variations in the branching pattern, but one significant anomaly is a double arch of the aorta. Instead of a single arch, the aorta splits and forms a complete vascular ring around the structures passing through the mediastinum.
A ring around what?
Around the trachea, the windpipe, and the esophagus, the food pipe. If this ring is tight, it can compress the trachea, especially in infants, causing serious breathing difficulties, stridor, wheezing that might require surgery to divide the ring.
And what about problems with the aorta itself in this region, like an aneurysm?
Yes, the ascending aorta, just as it leaves the heart and before it arches, is susceptible to forming an aneurysm, which is a localized bulge or dilation of the vessel wall.
Why is that part vulnerable?
Partially because the very beginning of the ascending aorta isn't enclosed within the tough, fibrous pericardium, unlike the heart chambers. It lacks that external support. Combined with the very high-pressure blood being injected directly into it from the left ventricle, it's prone to weakening and dilating over time, especially with conditions like hypertension or certain connective tissue disorders.
What kind of symptoms would an expanding aneurysm in the superior mediastinum cause? Besides chest pain, perhaps.
The real danger often comes from pressure on surrounding structures. It can press on the trachea or main bronchi, causing persistent cough, shortness of breath, or wheezing. It can compress the esophagus, leading to difficulty swallowing, dysphagia.
And nerves?
Critically, yes. It can press on the left recurrent laryngeal nerve. This nerve branches off the vagus nerve, loops underneath the arch of the aorta, and then travels back up to supply the left vocal cord. Compression of this nerve is common with aortic arch aneurysms and causes hoarseness or a change in voice quality. That can actually be a presenting sign.
So hoarseness could be a sign of an aortic problem. Okay, moving deeper still. Behind the arteries, what do we find?
We find the major conduits for air and food. The trachea lies anteriorly, continuing down from the neck to where it bifurcates into the main bronchi, usually just below the level of the superior mediastinum. Posterior to the trachea is the esophagus.
The food pipe.
Right. It's traveling down from the pharynx to the stomach, lying directly anterior to the vertebral bodies T1, T4 in this region. It's usually somewhat flattened front to back here.
Is the esophagus vulnerable here too? Maybe to swallowed objects getting stuck?
Yes. The esophagus naturally has a few points where it's slightly narrowed by adjacent structures. One of the most significant constrictions is where the arch of the aorta presses against it from the front and left side. This is a common site for swallowed foreign objects like coins in children or large pieces of food in adults to become lodged. It's also a potential site for strictures to develop.
Okay, so we have thymus, veins, arteries, trachea, esophagus. Anything else major packed in there?
Nerves and lymphatics are the main other components. Important nerves like the vagus nerves and the phrenic nerves supplying the diaphragm pass through. And crucially, the largest lymphatic vessel in the body, the thoracic duct, ascends through the superior mediastinum.
The thoracic duct, why is it so significant?
Because it collects lymph fluid drained from tissues from the entire lower body below the diaphragm, and the left side of the upper body, left head, neck, chest, and left arm. That's a huge territory.
So most of the body's lymph fluid drains via this one duct.
The majority of it, yes. It travels up, typically lying between the aorta and the esophagus posteriorly, and then arches over in the root of the neck to empty back into the venous system, usually near the junction of the left internal jugular vein and the left subclavian vein.
Wow. So this relatively small space, the superior mediastinum, contains the main highways for blood going out, aorta branches, blood coming back, SVC brachiocephalics, air going in, trachea, food going down, esophagus, and lymph returning. It's incredibly crowded and vital.
It truly is. Everything has to pass through this gateway. And you can see how pathology in one structure, like that aortic aneurysm, can quickly impact multiple other systems: breathing, swallowing, voice, venous return.
Yeah.
It's all intimately connected. Hashtag tag outro.
Well, that was an incredibly detailed journey, taking us right inside the heart and then looking at its crucial connections in the superior mediastinum. We really moved beyond just the surface.
We did. We look at how the internal structure, like the smooth sinus venorum versus the rough pectinate muscles, reflects function and development. We unpacked the crucial pressure changes at birth that close the oval foramen and the problems caused by leftover holes like ASDs and especially VSDs in that vulnerable membranous septum.
And the electrical system, understanding the SA node pacemaker, the vital AV node delay, the insulating fibrous skeleton, and that clever shortcut, the septomarginal trabecula, ensuring the valves are braced just in time.
Plus that elegant mechanism of coronary artery filling during diastole, driven by aortic recoil and valve closure, highlighting the heart's dependence on its own rest periods. We traced the main coronary arteries, the RCA and LCA, understanding why the LAD is so often implicated in devastating heart attacks.
And we saw how damage to that system leads to heart block, necessitating artificial pacemakers, which are threaded right through those venous pathways we discussed.
Then navigating the superior mediastinum, layer by layer thymus, veins like the vital SVC, the aortic arch with its critical branches, the trachea and esophagus, and even the huge thoracic duct. We saw how an aneurysm there can cause symptoms far beyond just chest pain, like hoarseness from nerve compression.
It really underscores the interconnectedness. Which brings us to a final thought. You detailed the tricuspid, 3 cusps, and mitral, 2 cusps, valves, both relying on papillary muscles and chordae. The mitral valve handles much higher pressure, yet only has 2 leaflets. Why do you think mitral valve insufficiency or prolapse seems clinically more common or problematic than tricuspid valve issues, despite the tricuspid having seemingly 1 extra cusp for support? Is it just the pressure, or something about the bicuspid design itself under stress?
That's a fantastic question to ponder. Is the bicuspid structure inherently less stable under extreme prolonged systemic pressure compared to the tricuspid design facing lower pulmonary pressures? Or are the stresses distributed differently? Definitely something worth looking into further.
Indeed, a great point to leave us thinking. Thank you once again for guiding us through this complex anatomy with such clarity.
It was my pleasure.
Next time, we'll wrap up our exploration of the thorax. We'll be diving into the remaining parts of the mediastinum, the posterior and anterior divisions, examining their contents and discussing the clinical relevance of what lies within those spaces.
Looking forward to completing our journey through the chest cavity.
Us too. Thanks for listening to Bookfulness.